Hey, well, hello, everyone, and welcome to the Donald Institute for Global Health Research seminar today. I'm Mary Viktorovich, the interim director, and we're delighted today to host our speakers, Drs. Ramia Kumar and Anima Byrne. But before we get started, I'd like to acknowledge the land we're currently on. So, and as this is a hybrid event, and some participants are on different territories, we ask that you take some time to give thanks and gratitude and respect for the land you're currently living and working on. Today, we're here at York University, that's in Toronto, otherwise known as Toronto, and the traditional treaty holders are the Mississaugas of the Credit First Nation. We also acknowledge this as a traditional territorial area of many Indigenous nations, including the Anishinaabe, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. This territory is also subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably care and share for the Great Lakes region. So with that, let me introduce our speakers. Dr. Ramia Kumar is a senior lecturer and medical doctor with the Department of Community and Family Medicine in the Faculty of Medicine at the University of Jaffna in northern Sri Lanka. In 2023, she was a postdoctoral research fellow at the UN University International Institute for Global Health in Kuala Lumpur, Malaysia. Ramia's research interests include access to healthcare, politics of global health, gender and health, applying critical feminist methodologies to health research. Her recent work explores health policy, health reform and gender and health, focusing primarily on Sri Lanka and global health policy and politics. And this includes the volume that she'll discuss today, Going Public, the Unmaking and Remaking of Universal Healthcare. And this was co-authored with Dr. Anima Byrne, who is a professor of global development studies and of social and behavioral health sciences at the Dalai Lama Institute for Global Health Research. The Dalai Lama School of Public Health at the U of T. Previously, she was a professor in the New School in New York and worked at the Pan American Health Organization and has been a visiting professor in Montevideo, Paris, Lisbon, and the WHO. Her research explores the history, politics, and political economy of global health, particularly in Latin America. A former Canada Research Chair in International Health, she's been recognized as among the top 100 women leaders in global health and was named to the list of Canadian women in global health. With that, I pass it over to you.
Thank you so much for the generous invitation to the two of us. We're really delighted. This is actually, in some ways, a book launch, even though it came out 2 years ago, because we have yet to really speak about the book publicly. We're most grateful to the Dadala Institute, as well as to Professor Mary Viktorovich and Natalie Patterson and all of the support staff who made this event possible and made our stay here possible. So we're really most grateful. So I'm going to get us started, and then I will turn over to Dr. Kumar. So a little excitement just to get us going. That's always fun. Oh, there we go. So I want to start with a bit of the genesis of the book and how we came to both to write it together, but also the nature, the shape it took and it has taken. So it started with an invitation from an anthropologist who was at the University of Sussex in International Development Studies at the time, a fellow named Ben Hunter, who's now moved on to Glasgow. And he was proposing a series for this Cambridge Elements in Global Development Studies. So I was tempted to turn down the invitation, but then I realized, well, this is the name of my very department, Global Development Studies. It might be both fortuitous and propitious for me to participate in this series, but I really didn't think it was appropriate for me either as a scholar based in the global north, nor given my own positionality, to author this alone or even to lead author this book. And I immediately thought of a former student. Alas, I was not Dr. Kumar's supervisor, but maybe quasi, at least towards the end as her supervisor retired. And we had written a little bit together, and I knew of and continued to stay in touch with Dr. Kumar and was really most struck by the acuity with which she has tackled questions of privatization of health services, particularly in relation to women's health access within Sri Lanka, and also thinking about this in global perspective. So that's how the book got started. It was one of these COVID books, so we had a lot of back and forth for, well over a year, maybe two, debating the different sections and devising the book. And I was delighted when Ramya suggested that it really start with a needed historical perspective. And of course, that's where I'm able to contribute. So this is just a very brief outline of what we'll be discussing today. I'll probably take on the first two and then turn it over to Dr. Kumar and jump back in around the Q&A. And what's particularly of interest is this paradox or contradiction. You can see our fancy work with graphics on the top right here, corporate greed, and I don't know how many of you are familiar with this image from the days of the Alma Ata conference of Health for All. And, you know, thinking about this from it's actually from the early 80s, it's an incredibly heartening slide, I think, or a set of images about solidarity across peoples and classes and genders and so on. So a bit of the backstory. I had, let me begin just with a couple of definitions, and then I'll get to the backstory. So going public here refers to two rather contradictory elements. So public means, as many of you are familiar, public financing and coverage. But when a company goes, quote unquote, public, that means they sell stock, list on the stock exchange. So they're private companies, but they have at least a modicum of accountability in that shareholders will vote on their larger agendas, perhaps force out leaders and so on. But of course, in going public in that sense, they seek to maximize the profits for shareholders. So it's a paradox in being public, but amassing power, control, resources in private players. And then we also think about public in a more aspirational sense of the role people play in shaping their healthcare systems. So the book reflects this contradiction paradox, and both our critique and our vision, but in many ways aspirations. So I think we would both consider ourselves scholar activists in that regard. So in terms of the backstory, I had written a piece with my Argentinian and New Mexican colleague, Laura Nervi, some years ago, trying to unpack the popularity, the fashion, it seemed, of this UHC trend. And we really tried to take apart this notion of universal health coverage as highly, as we say here, delusional, deluded in a watering down sense, and a deviation towards health justice or universal health justice. And so despite some of the more optimistic, you might say, language of WHO just this year, this idea of having access to full range of quality health services when and where people need them without financial hardship, is actually highly problematic in and of itself, and we'll be looking at language quite a bit this afternoon. And this, of course, is compounded by the entry, the consolidation of what we call global health Inc., that is to say, corporatization of global health. So the research questions that we pose in the book are listed here. So dominant understandings evolving since the late 1970s. What are the implications of this social innovation mentality and approach for primary care, or so-called primary care initiatives that are rolled out in what the World Bank defines as low income or the lowest income countries? And then what can we learn from public sector variants that might propitiously inform or transform this approach? So drawing from the textbook of global health with Jürgen Pillay, Tim Holtz, we have employed a critical political economy of health approach. So power relations are centered, the role of political and economic systems, the rules of the game, key actors, and their values and priorities. We're looking at both understanding and naming, and perhaps we'll include shaming, who and what drives inequity and perpetuates inequality in healthcare, and then seeking to problematize much of the language. So I just mentioned the low-income country, or LMICs, as well. Here we have a preferred language of majority world, meaning what many call the global South, or back in the days of the Cold War, more referred to as the third world, and also problematizing the ways in which primary care has been co-opted by UHC and other forces over time. So this historical overview that will be really kaleidoscoped looks at the last 50 years or 5 decades or so, imagining this field and tracing this field from the days of the preparation for and the conference of Alma-Ata, the Declaration of Health for All in the year 2000, its transmogrification into selective primary health care, the way in which user fees and cost recovery mechanisms were taken up, promoted by the World Bank and other actors, this idea of investing in health and what it signified by the 2000s, 1990s and 2000s, the emergence, what I prefer to call re-emergence of philanthrocapitalism, since it was very much present in the early 20th century, and we can get to that in the Q&A if you're interested. And then finally, this era of UHC. So just a quick reminder that the Alma-Ata conference held in the USSR in September of 1978 convened 134 countries, almost 70 NGOs, 3,000 participants, who by acclamation supported this declaration of Alma-Ata. And again, I can tell you much more of the backstory, especially on the Soviet side, which is less well known. I interviewed some of these key players, like you can see here in the middle slide, Dmitry Venediktov, the representative of the USSR at the Alma-Ata conference and at WHO. In any case, this was a conference that signified this idea of third world advocacy and priorities, really flipping the agenda of what was known as international health. So instead of top-down, so-called vertical campaigns against disease by disease, the malaria campaign, smallpox campaign, and others, a transformation into a more horizontal approach, grounded politically, socially acceptable, scientifically sound, and this term universal was also utilized. And as well, the participants heeded the call of the G77 grouping of non-aligned countries within the United Nations for a new international economic order. So sovereignty, fair terms of trade, full participation, recognition on the global stage, and so on. And of course, the well-known goal of health for all by the year 2000. So there certainly was revolutionary potential of Alma-Ata under the leadership of the Director General, Halfdan Mahler, and especially a number of participants from member countries. And here you can see this language: health is a fundamental human right, the existing gross inequality across the world and between countries being politically, socially, and economically unacceptable. And then this call for governments having responsibility for the health of their populations, people having the right to participate, and this longer idea of governments formulating national policies, strategies, plans of action to sustain PHC as part of larger integrated national health systems or intersectoral approaches. So what is less known is the extent to which US and allied delegates forced the declaration to omit, sidestep the question of public funding, and particularly government-run or public healthcare systems. This was not mentioned. It's actually very deft language because it slips around. So there's no call for government financing or delivery of healthcare. Now, that said, there was a misconception, especially in Latin American countries, that PHC was to be healthcare for the poor. And this misconception was actually overturned, if you will, revived in 2005 with the Declaration of Montevideo. And so in that regard, it's important to remember that there was a big struggle at Alma-Ata, because there's so much these days recognition and maybe nostalgia, as Laura Nervi and I argued. There is, this is a time to say adios or goodbye to nostalgia, right? And we can talk about that in more detail later. But in any case, the Alma-Ata agenda was quickly narrowed down, reduced to this selective primary healthcare approach. Again, many of you may be familiar with this famed piece penned by a Rockefeller Foundation head of Health Sciences Division, Ken Warren, and a consultant he hired who I interviewed, again, a separate story. But they argued that it was a great goal, very laudable, PHC, but it was simply not realistic. And so within a year, really 6 months of the issuance of the Declaration of Alma-Ata, they called for a rational approach, and in many ways, a return to these top-down technical reductionist approaches like vector control, oral rehydration, and immunization, without addressing social conditions, nutrition, sanitation, and so on. And UNICEF took, together with the World Bank, the Rockefeller Foundation, WHO, and a few other players, took on the mantle of SPHC in the guise of child survival campaigns. And again, we can talk about them a little later on. So by the 1980s, you have a full-fledged ascendancy of neoliberalism in healthcare. This is embodied in many ways by the Bamako initiative that was promoted by the World Bank and WHO. WHO by this time suffering tremendously financially, not unlike its situation today, and so partnered with the bank in promoting PHC in sub-Saharan Africa with how shall we say, the forced or compelled consent, shall we say, of African ministers of health. And it was financed through this cost recovery approach, user fees, and that based on this ideology that if people paid for their care, they would value it more and it would become much more efficient. Of course, ultimately it left the poor even more excluded, and the World Bank had never tested out this approach and apologized sort of half-heartedly some 20 years later after this was, about 20 years later, after this was a very clearly a major factor in causing the increase in death and illness from preventable causes. So this is the user fee side, and then just a bit of background. Again, you're all very familiar with, I'm sure, with the Washington Consensus of government downsizing, and in particular here, the decrease in public spending of social services and its replacement with privatization. By the early 1990s, with WHO arguably in full-fledged crisis, you have a new model that steps in, which are public-private partnerships. And we tend to think of some of the bigger ones, the largest one in the world, of course, the Global Fund, Gavi Vaccine Alliance, both launched by the Bill and Melinda Gates Foundation circa 2000. But this model initially was proposed by the Rockefeller Foundation and called for this infusion of money from private actors, which was, of course, a double-edged sword, or maybe it was only one side of a sword, because what it did was essentially call for a partnering that gave enormous agenda-setting access, arguably influence or control, to private actors, right? That we let the door in, no accountability for the most part for these. And the end result was a vilification of the public sector, a whole series of conflicts of interest whereby these private actors were actually profiting through the PPPs by promoting their own products. They got legitimacy via access and association with the UN. And again, this real entrenchment of vertical approaches. So I'm putting in here some of the older, longer standing PPPs from the early 90s or mid 90s, some of them, just so you get a sense of how this really predated the largest ones that you're most familiar with. And so by the 1990s and into the 2000s, you have legitimization of market approaches to healthcare. There's this double entendre of investing in health, meaning bringing money to the healthcare sector, which the PPPs, of course, proposed, and at the same time investing in terms of private investors and the potential to profit. And this was crystallized into very famous and contentious reports, the World Bank's 1993 WDR, and then the 2002 WHO Commission on Macroeconomics and Health, both of which had investing in health as the main title. By the year 2000, the early 2000s, you have the entry or re-entry, re-emergence of major philanthropacapitalists. Here, not just the Bill and Melinda Gates Foundation, or the Gates Foundation is now known, but many other players, including in the global South and or the majority world, I should say. And what I wanted to highlight here is how a worker's perspective, people's perspective, are actually so much more savvy and on the pulse in many ways than that of scholars and health policy experts who themselves or ourselves may be, how shall I say, complicit or problematic in this story. And so this is some graffiti on the upper right here that I stumbled upon in Kochi in Kerala. And this, of course, refers to the Tata family in India. And so we have Tata funds here on the lower right, and Tata kills. So we have this contradiction that workers, local folks themselves are recognizing. There's nothing better than people's graffiti to get to the core of analysis. So again, in terms of the early emergence of the UHC model, the Rockefeller Foundation emerges. So in the late 2000s, 2009, and a bit onwards, this idea of health for all, perhaps we could argue co-opted. So harnessing the resources of the private sector to finance and deliver health services for poor people. And this was on the back of this idea of impact investing that the Rockefeller Foundation put forth, which is the idea of investing in social problems and turning a profit at the same time, which of course is one of the fundamental critiques embedded in our book. So just a couple more slides here before I turn over to Dr. Kumar. So the World Health Organization's 2010 report said that, building on this concern around bankruptcy for paying for health services, due to paying for health services, this idea of ensuring that all people have access to services without suffering financial hardship. And then the clarification, or one could argue Baudelarization on the part of the World Bank, access to the healthcare they need, right? So here we don't have reference to primary healthcare or to the public domain. And yet by 2015, Director General Margaret Chan could say universal health coverage is one of the most powerful social equalizers. It's the ultimate expression of fairness. If something, and this sounds almost like a movie line, if public health has something that can help our troubled, out of balance world, it is this growing evidence that well-functioning and inclusive health systems contribute to social cohesion, equity, and stability, right? So this incredibly aspirational an explanation here of UHC, and yet not grappling at all with many of its problems. So at one level, we have a slippery approach, right? So universal for whom and what? I mean, even the idea of universal comes etymologically from the idea of a joint at the fulcrum of a mechanisms of a machine. So very imprecise and masking a definition that departs from universal health care, right, as opposed to health coverage. And of course, coverage itself is an entirely ambiguous statement. It refers to insurance coverage, not necessarily care per se. And it was developed in 1912 in conjunction with the US insurance industry when there was one of the early efforts to nationalize public health, of course, a perennial problem to this day in the United States. And so we have this experience of marketization with often very regressive financing. So this is the famous UHC cube that WHO put forth. So again, presupposing insurance-based financing and maybe mixed public-private delivery. The state's role is limited to oversight, regulation, what's called stewardship, at least in theory, accountability of both public and private sectors, and came in conjunction with this larger scale effort to expand the role of the private sector in healthcare. And so 50 years ago, there was, in the context of Alma-Ata, there was no mention at all of the private sector, not of the public funding and financing, but at least the private sector was left out. And it's also important to note that UHC, or some attention to health care and access to health care, was not included in the Millennium Development Goals, but of course is a prominent plank of the Sustainable Development Goals. And we can debate what the significance is, at least in terms of the extent to which the SDGs are very much more in the business of promoting business, put it that way, right? So again, just a few ways of thinking through this set of contradictions, public versus private delivery, public versus private insurance, single-tiered versus multi-tiered systems, equitable versus regressive revenue sources, and so on. And as my colleague Juliana Martinez-Franzoni argues, if everyone has access to some healthcare benefits, but only a few have their cancer treatment covered, there's no universalism to speak of. So really putting it in very concrete terms there.
Thank you so much. Thank you so much, Mary and Natalie, for making it possible for me to be here today. I'm really grateful, and it's really wonderful to be in Canada again. I did my PhD between 2011 and 2016, and so it's been quite a while. And then I returned to Sri Lanka. And yeah, and the background of the book. So right, so Annie Manuel, I guess I should say Professor Byrne. I'm calling me Dr. Kumar, please don't. So anyway, Ramya, and yeah, so I'll just continue from where Annie Manuel stopped. So we see this, a growing involvement of corporate actors in global health and in UHC. And so the rise of what we, now has been kind of normalized as what happens in global health, these multi-stakeholder initiatives. And then there's UHC 2030, which is a multi-stakeholder initiative aiming to accelerate progress on UHC. So as you can see, these multi-stakeholder initiatives are made up of governments, multilaterals, philanthropies, NGOs, and the private sector. And they legitimize the role of the private sector in UHC. So as you can see, the private sector constituencies include Apollo hospitals and all these different, big pharma, and as well as digital technology companies and all that now sort of having a more legitimized role in UHC. And what's interesting is that if you consider UHC indicators, right? I mean, some time ago we saw and the World Bank still reports on these indicators on how, what kind of percentage of healthcare is delivered by the public sector or the private sector or the public and private expenditures and so on. So, but now these UHC indicators also do not really track the extent of public and private involvement, which kind of invisibilizes the role of private actors in healthcare. So you have UHC coverage indices that just talk about coverage, but there's no discussion of what is public, what is private. So I think that's an important point to note. So we anyway, that's sort of a side point. But so what we oops, sorry, yeah. So this brings us to the second question in the in going public. So Anne Emanuel addressed the first one, which was about the evolving meanings of universal healthcare since the 1970s to now. And then we also wanted to look at, okay, so there's some literature on what corporatization has done in high-income countries and certain middle-income countries, particularly in relation to the commercial hospital industry, but not so much about, okay, what's going on, like how does all this play out in World Bank defined low-income countries. And in these countries, right, there's the solution is seen as social innovation. So what are these social innovations? So according to the Social Innovations in Health Initiative at TDR, they define them as locally grown solutions that provide creative and unconventional approaches to fixing the world's most complex and wicked problems. So then social innovations kind of frame these problems as problems that can be resolved with, resolved by, if you can if you're not impeded by government bureaucracies, and there are these individuals who have these very innovative ideas that they can just come in and design solutions to address these problems. So what we found when analyzing some of these social innovations is that, and I'll be talking about an example a little later. So they tend to be cheaper, that is cost effective, technology based, and they target lower end niche markets. They involve some kind of task shifting that is less trained healthcare providers, I guess, in primary care, taking on the work, and they are often linked to corporate social responsibility initiatives. So going into the literature, what we found is that this social innovation model draws on the catalytic model of innovation proposed by Christensen and colleagues in the Harvard Business Review in 2006. So they proposed these innovations to design more efficient alternatives that target less demanding consumers in lower end markets to achieve social goals. So that's where, when you look into the language of what these social innovations mean, you actually see that they draw on this very market-based model, although they are presented as locally grown solutions and so on. Right, so that's the social. So what we did was we analyzed, right, some of the case studies that have been posted on the Social Innovations in Health Initiative website at TDR. There are more than 40 case studies, and you can have a look at them. They are from across Africa, Asia, Latin America, and the Caribbean. And we selected 3 to we selected them to represent the diversity of what these innovations are. And also they're quite representative of what, the studies that are have been described on this website, right? And most of them do, in fact, come from the African continent, although there are a few from these other places. So we selected Chipatala Chapafoni, a mobile hotline service in Malawi, a Ugandan pilot project to engage private drug sellers to treat childhood fever, and also One Family Health Rwanda, a franchise that places nurses in rural health posts. So I'm going to go into the last one to kind of highlight some of the problems that we identified with this model. Okay, so One Family Health Rwanda is it was founded in 2012 by Gunther Faber, who was a former VP of GSK, Sub-Saharan Africa. And it's a low-profit, limited liability franchising company, which essentially means that it's got a different tax. It's a more flexible governance structure, and also individuals own these companies rather than shareholders, and they have less stringent tax requirements and so on. So what they did was, what they aimed to do was make nurses at a lower tier of training. They recruited them to function as nurse entrepreneurs. There you see the language of business coming in. And the idea was to extend primary care to rural and mountainous regions of Rwanda. So at present, there are over 110 health posts, which operate in 14 of the 30 districts in the country. This is a screenshot of their website, and they claim that they bring essential healthcare to 1.6 million people in rural Rwanda. And this is not to discredit these initiatives or to criticize, the work of well-meaning individuals, but it's more to look at, what this particular model means for access to healthcare and whether they really work in terms of UHC. And what that means, in terms of what we think is okay for as healthcare alternatives in these very poverty-stricken settings. Okay. So how do these nurses set up business, right? So then they get low-interest loans for clinic equipment, medical supplies, which are repayable over a 5-year period. And these loans are from EcoBank, which is a Pan-African bank, and there's a typo there, a co-partner of One Family Health. And the medicines are delivered by the company to the health post. And these nurses receive training in primary care protocols through an open source platform available via a mobile phone with an internet connection. And it's a week-long training. So just to say, as someone, my background is in medicine, and I worked with the Ministry of Health in Sri Lanka for a number of years before going into public health. And, this kind of, so it's sort of, I'll be comparing this sort of model with what's happening in Sri Lanka. And so for me, as someone who's worked in that system, this seems, very wrong. So there are these nurses who are now going to the idea is that they set up businesses so that they become, this language of sustainability comes up here, because once the nurses become, sort of create their own profit or whatever, their income, then that's called sustainable. But what does that mean in terms of their work? And also this kind of training of people, there's some task shifting happening here. And then there's a weeks-long training. The whole thing sounds very weak as a model of primary healthcare for me. So let's just go into it further, right? So the current funders of this initiative are GSK, Pfizer, UCB, and USAID. I'm not sure about USAID anymore, but it's still listed on the website. And this is a public-private partnership with the government of Rwanda. And very often now, when we talk about sustainability and the nurses sort of running their own businesses, we kind of forget the public-private partnership angle of many of these social innovations, not just this one. So the government funds the services under their community-based health insurance scheme. And then the government also gives free use of public lands and buildings. So there is considerable subsidization of this PPP by the Rwandan government. And in the meantime, the company generates revenues from franchise royalty fees paid by nurses. So that's 6% of their monthly earnings, a margin on the distribution of medicines of 3%, a US dollars 500 fee to enter the franchise, also paid by nurses, and they also direct 2% of monthly earnings to marketing. And then there's the margin on sales of medicines to those who seek healthcare. So this is, there's extraction happening here. That's how we see this. And then there's the evaluations done of this particular innovation. So the 2018 review, which is an independent review of the community-based health insurance scheme undertaken through the Ministry of Health, showed that there's greater service utilization at the one family health post compared to Ministry of Health post. And they suggest that it could be because of the supply of medicines, continuous supply of medicines. And then 2015 OFHR commissioned evaluation shows that travel time fell, there were shorter wait times, there was better continuity of care, and they integrated health promotion and disease prevention. So all this sounds nice, right? However, these evaluations do not really look at the health outcomes against Ministry of Health clinics, and what happens when provider income is linked to service use, how nurses manage these overheads, which were pretty steep, and how people manage the out-of-pocket payments associated with these services. So a Duke analysis 5 years in suggests that 60% of these posts are profitable or sustainable. So the income for nurses can come from insurance reimbursements and patient co-payments. And in 2015, this is how much they paid, right? So enrollees paid US dollars, $1.20 to $1.50 out of pocket per consultation at a rural post, and those without coverage had to pay $2 to $4 plus the co-payment. So what they're expecting is for the Ministry of Health to have savings of US dollars 3,600 per nurse. And eventually, once it's scaled up to 500 posts, for the government to save 15% of the health budget. That is according to this Duke analysis. And so this is what is called sustainable, right? So what is the meaning of sustainable here? The income for nurses is paid through the government and also people paying for their health care. So I think we really need to question how this use of the language sustainable, and I think it seeped into the Sustainable Development Goals, and it's all sort of part of this discourse, what that really means. So just a little bit to understand, okay, so then what we did was we took each of these innovations and placed them in context to see how, whether this actually addressed the gap in the particular healthcare system context. So just to compare Rwanda with OECD averages, and to note, we did not select like the worst scenarios to analyze. Rwanda is considered a strong health system in sub-Saharan Africa. So looking at GDP per capita, it's just under $1,000 in Rwanda versus 48,000 OECD average. So, but the reason why, so if we think of it as $1,000, which is like less than $3 per day, you can think about how much those co-payments and user fees actually mean in a setting where poverty rates are very high. And you can see the maternal mortality ratio, which is actually quite a bit lower than other countries in sub-Saharan Africa, where MMRs are over 1,000, right? But still quite high. And just to bring your attention to the nurses and midwives per 1,000 population, which is 0.9. And the government health expenditure per capita, $27, which was actually much higher, 3 times as much as in Uganda and Malawi, where we analyzed the other social innovations. And then this is also interesting, the external health expenditure as a percentage of current health expenditure is quite high at 43%. Right, which is an interesting point to note in relation to the case studies that we discuss later of PHC systems. So Rwanda currently, like I don't know whether it's the situation right now because we couldn't really find updated statistics, because we're seeing less and less of the statistics actually analyzing differences between public and private. So in 2017, you see that they have tiered health services in the public sector, and the private sector was much smaller, whereas the public system has community health workers, health posts, health centers, and connected to referral centers and so on. So there is a system there, right? So why are we then introducing another system to a place where that already has a system? And there's 90% coverage through this community-based health insurance scheme, but it requires households to purchase premiums, and only a quarter are subsidized by the government. However, there's impressive coverage rates, and although services are located at a distance and there's an acute shortage of health workers, long wait times, opportunity costs. So then the question is, why in a country where there is such a system, this particular model was of social innovation was considered the solution for areas that did not have access to primary care. So then what is actually innovative about this innovation? So what it is that nurses they begin to run their own businesses, and they're sustainable, meaning that there's some form of cost recovery, which is coming from the public. And then there's a very extractive company that's taking all this money from nurses. And also, what kind of vision of UHG does this franchising further? So it covered 10% of the population, according to the website, in mountainous regions. But then the service package was very limited. They didn't have maternal health care. And in terms of financial risk protection, which is the other arm of the UHC cube, it didn't really work that well either. So who actually benefits? Is it the people who get the companies that get a good reputation? Is it the owners of this limited liability company? Then what about the nurses? What about the people? And what have these evaluations missed? Do they consider the subsidies? Do they, from the government, the evaluations don't really look into those things? And also, what about, how people dealt with the out-of-pocket expenditures? How did the nurses manage these overheads? None of this is in the evaluations of this, of this social innovation. So then this brings us to the third question. which is what we can learn from public sector driven models of PHC. So here we looked at 3 case studies. One is Sri Lanka's universal and public maternal and infant care system, Thailand's long-standing national effort to retain rural health workers, and Cuba's family doctor and nurse program. So we focus on 1 and 3 here because they are more relevant to One Family Health, Rwanda. So you see a contrasting approach, right, where in Sri Lanka. So all these countries were at some point in different periods of their history, very poor countries, right? But then this is what they're doing in terms of primary care at present. So in Sri Lanka, there's a network of primary care facilities covering the entire country. They are linked to secondary and tertiary facilities. There are PHC workers at all levels, including ambulance drivers, midwives, nurses, doctors, etc. And they are linked to emergency obstetric care. There are midwives who carry out home visits, no fees at points of delivery. They're financed, administered, and delivered by the state. Similarly, in Cuba's family doctor and nurse program, you see community-oriented PHC with teams of doctors, nurses, and public health practitioners. It integrates health promotion, prevention, treatment, and there's action on some of the social determinants of health, like water, sanitation, environment, and so on. There are clinics located within each neighborhood, and each family is, they have home visits and follow-ups. There are detailed health records maintained. And again, no fees at points of delivery, financed, administered, and delivered by the state. So certain common themes come up in these PHC models that we sort of contrast with that social innovations approach, which is the model that's assumed to be the best for very poor countries and settings. So some of the themes we identified is that in the PHC studies, model, state investment is very crucial. There's been extensive investment in improving geographic and economic accessibility. Healthcare professions are trained locally in government subsidized diploma and degree programs. Healthcare is still free to different extents with no user charges at points of delivery in these case studies. Financing, administration, and delivery are to a great extent in the public sector, enabling governments to keep costs down. All 3 countries prioritize resources for rural health services at different periods of their history. In Sri Lanka, after 1930s malaria epidemic, and in parallel strengthening left movement, Cuba following the communist revolution, and Thailand after 1970s uprisings against military regimes and medical activism. So they've all put a lot of investment into rural development much before, far earlier than the WHO Commission on Social Determinants of Health in 2008. And they rely on a high degree of community engagement through grassroots workers. And Thailand and Cuba at least have mechanisms of accountability built into the systems via health commissions. So another interesting point to note that all these 3 countries have at some point rebuffed IFIs and donors. So a 2008 World Bank Commission study of UHC in Sri Lanka pointed out that they had made these achievements despite rejection of health funding reforms again and again over the years. Thailand implemented its universal coverage scheme against World Bank and IMF advice. Cuba, of course, under blockade for years, has no dealings with IFIs. However, under funding cuts, public sector downsizing, market reforms, and privatization, Sri Lanka is at this point in time, the free health policy is uncertain. More than 50% of total health spending is in the private sector. In Thailand, their public sector reforms are curbing recruitment of health cadres to public service, weakening the rural health workforce. And in Cuba, there's, a healthcare system that's downsizing in pursuit of efficiency gains. So, and in all three countries, health tourism lures health workers, well, I should say health tourism or cooperation, because that's what it is in Cuba. But health workers are either, leaving the country or seeking private sector employment. So the conclusions in our little book for going public is that, this corporate vision has been long in the making since the 1980s, with the World Bank emerging as a lead player. Like, we've come to this point in time where pluralistic delivery within mixed systems is the norm, right? Governments have opened their healthcare sectors for domestic and foreign investment, making healthcare very profitable. There's widespread government subsidization, channeling public funds for private profit. And then, of course, with the engagement of philanthrocapitalist actors, and this, that's sort of driving these social innovation approaches through their grant schemes and so on. And we're seeing further corporatization of UHC. And another point we want to make is that, this approach also dehumanizes certain places and peoples, right? So Global Health Inc. led piecemeal interventions dispossess people of their entitlements. And there is a colonial double standard here, because, people in various who, regardless of where they're from, global health decision makers remain very distant from these intended beneficiaries. And this distance makes it possible for us to then, to select cost effectiveness as a way to decide, are these primary care interventions affordable for these kinds of people in these kinds of places that are far away, and is, it makes it acceptable for health technologies, to replace primary healthcare systems, right, for certain people. So then we ask the question, is this neo-colonialism dressed as universalism? So, I guess these are our final thoughts, that we need state-led redistribution, need to upend power asymmetries to ensure that everyone has access to PHC. This would involve transferring healthcare resources from curative to preventive, and scaling up rural services, and investing in the structural determinants of health, rejecting neoliberal policies in health and other sectors to end corporatization, or what we say, reclaiming or retaking the public. And this is our aspiration, to build public, equitable, and solidarity-based healthcare systems for all. Thank you so much. I hope it didn't take too much time.
Yeah, well, thank you so much, doctors. That was a really excellent presentation. And I just wanted to start off the questions with a comment. I first started off in health policy, Canadian health policy, teaching Canadian health policy. And I remember one class I had a lecture on how Canada ranked in the WHO rankings. This was back in 2002. And Canada was ranked as about somewhere in the 30th, 35th, 32nd. And I thought, what's going on here in Canada? We really pride our healthcare, our Canada Health Act, making healthcare accessible. And then I realized, oh my goodness, the standards, that the criteria for evaluation are a role for the private sector. And of course, we didn't have that. And I have to say that planted the seeds for my interest in what is going on at the WHO and globally. And so here we are now. So So let me just open it up then to questions, because I think you've done an amazing job of highlighting some great examples that really illustrate some of the issues and problems we've got to face. So, I think I saw Rupsha's hand first, so go ahead, Rupsha.
Thank you for the great presentation. I thought the insights that you had around the framing of language were really interesting, like the mention of how sometimes the language is a little too positive, or like we see this with the SGD goals where there's a time frame mentioned, and of course the time frame is just not realistic. And then there was a discussion in the later presentation about the idea of profitability and a sustainability being linked, and how there's a dichotomy with that, because just because something is profitable doesn't mean it's necessarily sustainable. And I was just wondering, do you feel the use of language by the WHO or by these sort of larger organizations is maybe too positive? And is that maybe a detriment when you try to implement some of these things?
In many ways, this kind of language co-optation is a sign of success of social movements in health, right? It's so powerful that something like a group like the People's Health Movement, really pushed for some kind of commission on social determinants of health, for example, right? So on one hand, it's a sign of success. On another, it's really a failure to heed the underlying principles and values that these social movements in health or movements for health justice are putting forth, right? But they become the accepted and dominant language. And so the private actors, as well as WHO kind of heeding their funders, engage in this kind of gymnastics in order to both sound as though they're listening to larger population movements and yet enable sufficient flexibility that the kinds of efforts that Ramya was describing in such great detail are possible, right? And can be furthered. Now that you continue.
I don't know. No, I'm okay with, yeah.
Okay, all right, thank you.
Thank you very much for that presentation. It was really instructive to have that history drawn out about the evolution of primary healthcare to universal coverage and what those terms mean and what forces drove that. It's really instructive and a great framework for us to take forward. And I really appreciated the second part as well about analyzing these different models and how they work. The question I had with respect to the Rwandan example, as sort of an exemplar of like a social innovation approach. And there's a concern there, of course, that there's this kind of extractivism happening from the public to pay for these services, and where does that money go? And I'm wondering, in that example, or more broadly across these social innovations, are these firms, are they for-profit or not-for-profit? Are they incorporated in those countries in which they're operating? Are they incorporated elsewhere? Who are the shareholders? Like where is that extracted revenue going? Is it being reinvested in the service to enable its scaling? Is it being used as profit? What do you see?
So in this particular example, the funding was coming from those, it's still being funded by the, big pharma, right? But so they're being called sustainable because the nurses are now sort of not funded by the government, although the insurance is. But that money goes into, because it's a limited liability company, the money goes to individuals like the owners of it. And it's got a board of directors, and they're all, you can have a look, right? They're all white people in the United States and so on. And then there's a lower level of leadership that's based in Rwanda. So this company is a a limited liability company in Rwanda, but there's a foundation in the United States that's linked with it. So I would assume that the money is going into the sort of the upkeep of it, but at the same time, there's so much more that the companies gain, right? Because of the CSR and visibility, but at the same time, it's like a very extractive model.
Is that a common kind of pattern across these social divisions?
So the ones we studied, so if you look at the phone service in Malawi, for instance, right, that involved, so Airtel was a co-partner, and then everyone had, if you use that service, they had to own an Airtel phone. And initially the calls were free, but then later onwards, they were not. And, other than that, there was all this, so then these digital solutions companies involved in designing these platforms, and they get funded through, say, Gates funding or whatever. They've given a lot of funding for these kinds of mHealth, right? So I would say that once again, that money goes back into investments in all these technologies, which become profitable on the long term, right? Because there's an expansion of the market for it.
But just to add, there's a slight different model between an LLC, a limited liability corporation, and a philanthropic foundation. That's important to underscore, at least in the context of North America. So an LLC operates pretty much like a company, and so it has public quarterly reports and so on, but does not come under the scrutiny of the federal government's tax revenue service unless there's some kind of issue. Whereas a philanthropy has to heed, that gets a tax break, has to heed rules of the IRS, the Internal Revenue Service, and periodically philanthropies have undergone interrogation. It happened in the McCarthy era in the 1950s. The Rockefeller Foundation, was subject to this, interrogation, if you will. So there's a different leeway in that sense, and you'll notice that some of the tech billionaires with so-called philanthropies like Zuckerberg, the Chan Zuckerberg initiative, is actually a limited liability corporation. So that it becomes even more nefarious in terms of any sense of accountability to the public as opposed to shareholders.
Thank you.
Yeah.
Councilor Willie, you had your hand up, right?
Thank you very much for the presentation, especially bringing kind of a very wide case study discussion. So I have a couple of questions, but one important question is the language used. Like you in the book also, and here in the slides, it was mentioned that there is issue related to the terminology investing in health and health as productivity. So I was just seeing from the other end as advocating to the governments, to the politicians, please invest in your health. Please see health as in productivity. So in this scenario, how will you take this kind of phrases, whether it is still wrong or it is right? Because I think throughout the book, it was most of a criticism of WHO or the international organizations related to using the terminologies, but a lot of time these phrases are used depending on the context and the time periods and whatever is happening. So your opinion on it. And second thing is there is a terminology used for this free health in the slide and also in the chapter, and one of the titles of the chapter, universal and free health. So for me, it's universal means it is free. And mostly as an emic perspective, free is actually an emic perspective. Universal is more of an ethic perspective. So what is your take on this?
In terms of investing in health, first, question. I think it's not so much about, whether it's a government should invest in a health system or not, but rather the sort of the underlying assumption of invest. So the idea is that you invest in people's health so that something comes, like, the investment then leads to economic growth. And then it makes sort of invisible the relationship between economy and health, and that health is actually an outcome of economy as well, works both ways. And then this discussion about, it was very much that, right, in the 1990s and in the 2000s, you put money into making people healthy in a very instrumental way to get economic profit or productivity and profit. And that's what I think that was what our point was, rather than criticizing or saying, no, like, we shouldn't use the word investing by governments and so on.
Yeah. And normalizing
Yeah.
this approach, right? Like pandemic bonds, the idea, right, that private investors should, take the opportunity to potentially profit from a pandemic, right? And there would be a backstop by IFIs and private banks. So it's a normalization. It's I completely agree. It's not that the language itself. I mean, this isn't a discourse analysis.
Yeah.
Free universal implies free. He said that universal.
Yeah. So I think free. So in Sri Lanka, there's a free health policy, which actually doesn't translate to simply no charges. It's much broader than that. It's more about people's aspirations and having a system that is, for the people kind of thing. So it's not like, if you translate that to local languages, it's not just no user charges, but that also means that. So I don't know whether so I think the very, the change in the language over time showed that free and universal were not the same thing. Right? They sort of co-opted universal to make it about coverage rather than whether people pay for healthcare or not. And in fact, in the original submission from the USSR, they did include free health services, but then that was removed. But universal is sort of kind of more acceptable. And also there's, although it's universal within a geographic context, not necessarily universal across the whole world, right? There are different standards even in the way Alma Ata was written.
Naima.
So yeah, thank you so much for your presentation. I think a lot of the discussion today made me think about global health reform in general, and how amidst a lot of the funding cuts to global health, thinking of philanthropists such as Mackenzie Scott, who has a no strings attached funding approach to nonprofit organizations globally, and looking at example or case studies like that, do you think it's institutions who have been historically funding a lot of global health projects would adopt? Do you think it's possible as we continue to think about the future of global health?
So global health reform is, of course, a huge question in the current moment. First of all, there's no way that the government financing in global health could be matched by even the richest philanthropies. Although, you know, with the proliferation of this handful of trillionaires in the making, if they were willing to give it all away, as it were, perhaps, but that's highly unlikely. It's usually a drop in the bucket. You know, no strings attached has been an approach that many South-South cooperation efforts have taken. The Chinese government is, you know, prides itself on no strings attached. In fact, much of the South-South health aid from China takes place at the decentralized level. And yet at the same time, right, as with the case of Brazil and India for that matter, there is a quid pro quo, which is whether it's mineral extraction or, you know, constructing Brazil's big Odebrecht construction company in Mozambique and so on. So, you know, the kind of true horizontality or this idea that there would never be strings or never could be strings attached at present, at least, appears a bit of a pipe dream.
Thank you for your presentations. I had a question about, so you mentioned two cases where they sort of refused financing. And I was just curious about whether you looked into what makes a government want to refuse financing. You think that's probably not typical. Did you look into a little bit more about why they might have said no to the financing?
It wasn't financing, it was a reform.
Okay.
So, yeah, so for instance, the World Bank comes in and, you know, they give these loans, and with those loans, they have certain recommendations on how to, you know, especially this purchaser-provider split and sort of moving towards an insurance-based system. The Ministry of Health has repeatedly rejected, in Sri Lanka, has repeatedly rejected that model. So I don't think they'd say no to financing in the sense of money,
Right.
but
So with the reform specifically, is there like reasons that maybe made them want to reject that? So I guess that's what I'm trying to understand.
oh, okay.
Other places maybe they would have gone that model, but is there something particular about Sri Lanka that kind of?
Okay, so as far as, I mean, I don't know a lot about this, but I know that there was a study undertaken in Sri Lanka through a collaboration between the Sri Lanka Medical Association and the Ministry of Health, where they actually looked at whether the country could afford in introducing insurance. And what they found was like, you know, now there's the system is highly oversubscribed. Anyone who has a problem can just go in, and this means that there are people sharing beds, and, you know, it's not at all an ideal situation. But if you move to like a insurance-based model, there has to be, you know, what they found through the analysis was that they couldn't afford that. Actually, they couldn't cover this number of people and do that through that kind of a model. And I think that's why. And also free health is very much in the sort of the public's, like if someone tries to stop that, that's going to be a problem politically.
Yeah, my question for you.
I think, sorry, I thought something.
That's all right. So the question was on the iPad there.
Maybe I can read. You want me to read the question?
Oh, right. Okay, I remember. So the question is, why would the World Bank and the IMF recommend against establishing a publicly funded healthcare scheme in Thailand? So I think here Thailand wanted to, they wanted a universal scheme, right, which was going to cost the country a lot. And the World Bank, and I mean the IMF, is all about reducing public expenditures to address economic crisis. So they would have, said no. It's that's what's happening in Sri Lanka right now is that we have all these IMF conditionalities which prevent the government from increasing expenditures in education, health, and so on. So I think this reform increased their expenditure in a big way and brought down out-of-pocket expenditures like to a very low level. Yeah.
Thank you so much for your insightful presentation. I wanted to know your thoughts about the quality of care vis-a-vis the various models you looked at. Was there anything you found, or what are your thoughts about how this could be related?
Yeah, so we didn't really go into like analyzing quality of care in these models. Did you mean in terms of the social innovations or in the case studies?
I can give you an example.
Yeah.
In some of the public funded approaches, you were talking about task shifting. And you will recall that in some of the areas, in providing maternal health services, we started using traditional birth attendants at some point. Okay, so in such settings, what do you think about quality compared to the use of midwives, for example, in other settings?
Oh, okay. So I haven't really looked into that. I don't feel comfortable commenting on the, the sort of this contestation about traditional and professionalized midwives and so on. But I think very basically, I mean, regardless of whether they're traditional or not, they need to be linked to some kind of system that is able to care for a bleeding, a hemorrhaging woman, for instance. And if that's not present, then that's not going to save lives and so on. So very often, I think the discussion becomes like a traditional versus professional midwives and which is better and so on. And I don't have an answer to that, but I think we should look at the broader system and whether it's strong enough to care for women who need this kind of treatment when it's needed. I don't know whether that answers your question.
Well, what about the Sri Lankan experience with it?
Yeah, so even in are you sort of questioning
The point is this. The point is this. The overall principle is that of equity, social justice, human rights for everyone, wherever they are, without any financial hardship. Does that translate into providing, accessing services? Does it translate into providing less quality services for certain groups of people? Would that be equity? Would that be social justice? Would that be human rights? That's the question.
Well, I think what we're...
Even before we come to the issue of financing mechanisms, we need to have these conversations first. Because if we say that we are on the same page, on the broad principles, I think that the issue is actually more of implementation bottlenecks and not conceptual. And so it's not about language. I think we seem to be we seem to be on the same page on the fundamental principles. But in terms of implementation, yes, we need to contextualize implementation. To what extent are we hearing the voices of the beneficiaries? And are we really providing services that fit into what we are talking about in terms of global health equity? So perhaps if we look into all of this, then we can look
Yeah.
at models that are appropriate for certain contexts. We're talking about the LMICs, okay, and then the other contexts. What probably the issue of universal will probably become clearer. Yes, universal in terms of access, okay, but it may not in the definition of health coverage. From the insurance perspective, we're talking about cost coverage. From the perspective of the providers, we're talking about is almost similar to access. So there's a difference.
Yeah, I mean, I would just agreed, and I would just say in this study, it was not an on the ground set of evaluations. What we were examining was the ways in which these privatizing and profit-making insurance schemes are being implemented across the world, almost in recipe-like fashion. I mean, I think Marin Aldada, who has worked on mHealth in Ghana and in India and elsewhere, has argued as well, and that doesn't incorporate in and of itself the very model quality of care, right? Or a differentiation, a reason for duplication of services, which is the case clearly in Rwanda. And as Ramya pointed out, both the official and the outside evaluations and the internal evaluations don't even bother to look at quality of care or health outcomes, right? They're looking at the finance side. So that's a huge part of the critique, right? So you're absolutely right in that regard, but that's not what this research was about.
Yeah, and also we do say, like, if you're the Ugandan study of private, drug sellers, like they were now training these drug sellers to treat children with fever. I mean, are we going to be okay with sending our children to someone with no kind of training at all now, who's going to just give RDTs and, treatment for malaria or antibiotics for pneumonia and what was the other, ORS for diarrhea? That's just the 3 treatments. And now these people are going to be replacing the alternative, which is a strong PHC system. So that is quality too, although we didn't look into quality per se.
There's a question in the back. Should we take, I mean, we're happy to stay a little bit. Can we take 3 questions, maybe all of us?
Well, we should probably wrap up in the next 4 minutes, I would say. So, I don't know, maybe one more question?
Well, and we can stay as well.
Okay, well, then maybe, a few stay, because we do have a.
Let's do the question.
If I have gathered well the outcome of the Alma then I could suggest that the most important progress on universal health care provision was made 50 years ago, and WHO has tried to sort of maintain that in all its different ways of articulating that universal health care, in spite of all the challenges that the organization has experienced. My question in that context is whether the challenge really in delivery of universal health care is not one of reconciling the different economic systems around the world towards delivering on this that was made so long ago.
A big question, and was Alma-Ata truly a high point? I mean, we were also certainly in terms of language, very aspirational, but in terms of concrete policy that could be implemented, far more problematic. So I don't even know if the starting point we would necessarily see as a high point. I think that the countries that have really tried to strive and struggle and maintain, or maybe further, greater equity and true comprehensive primary health care based services have been either politically left-leaning or communist regions like the state of Kerala, which has recently actually eradicated extreme poverty, one of the first places in the world to, not the only, but one of the first. I mean, Cuba's radical redistribution and, with all its problems and so on. So yes, this is ultimately a political question, and whether a kind of a one-size-fits-all policy recommendation from WHO works, I think is a big question mark. The problem is with many lower income countries as defined by the World Bank, there is quite limited maneuverability. I mean, if Rwanda is relying on for 42% of health spending on donors, there's just so much that's possible. Thailand was a different situation, although with other dilemmas like medical tourism. So, yeah.
So Sri Lanka, Thailand, less than 1% reliance on donor funding probably helps. And was there just ask a question and then just the question.
Me or somebody else?
I can.
Okay, just wanted to know, like, if there's any, sort of, in this type of, funding model, right? Is there any oversight, in relation to the quality of care? For example, if somebody dies, like, who's responsible for it, like, legally speaking, or are the patients really on their own? Because, like, in the case that, you've presented, if the recently graduated nurses are going into remote areas with 1 week of primary care training, I mean, a lot of things can go wrong, right? In the worst circumstances, like, who's really not liable, but accountable for it?
Yeah, that's the question. We don't know yet.
Yeah, we don't. I mean, what ideally it should be the companies that are furthering this model and profiting from it, but
So they have limited liability.
they have limited liability. And the stewardship remains in the hands of the government, right? But since they're private entrepreneurs, even that is removed. So it's a huge question of accountability in this kind of approach.
Yeah, and what that would mean when this sort of spreads everywhere and fragments the system. Yeah.
Oh, last question, I
Yes,
guess.
was very quick one.
Yeah.
You probably have touched upon it, but I was, by the way, thank you so much for such an insightful presentation. I was thinking, and I wanted to get your opinion on, with neoliberal thinking and expanding in such a wide scope in the strategies that you presented, realistically, to what extent can we expect to ever see universal health justice and equity in the global health aspect?
Question of the day. We care about these issues. We write about them with that, longer term aspiration, whether it's for this current moment, highly doubting, and we're seeing retrogression from the level of Ontario, right, to many other settings around the world. Does that mean one, gives up thinking through what you might call a shadow model? I would say absolutely not. The Brazilian unitary health system was imagined during the worst period of the Brazilian dictatorship in the 1970s, this idea of collective health. So they were prepared, as part of the larger political struggle, right, when democracy returned, and this incredibly progressive constitution with not just the right to health, but this, unifying of all these different patchwork programs and so on. So I guess,
There's hope.
Yeah,
to quote, yeah, of course, la lucha continua, right? The struggle continues and it's,
and if if everyone's politically engaged, and if people demand for healthcare, that's what I hope. And I do have hope, though. We can't really live without it.
yeah.
Okay,
All right, that was
thank you.